I'd like to welcome everybody who has logged on for today's webinar, Hospital Updates for 2019 and 2020, CMS and Medicaid Compliance. As always, I'm joined by Miss Cathy Costello, who I'll turn it over to here in just a second. But before we get started, I would like to remind everybody that if you are struggling with promoting interoperability, the MIPS program, quality reporting programs, or just keeping up with the yearly regulation, please keep CliniSyncPLUS in mind. We work with organizations across the state, both large and small, from the largest organizations down to single provider practices. We can do monthly meetings. We can work on a program to fit your needs. And being part of a not-for-profit organization, our fees are pretty low as well, very competitive. So if you're struggling, give us a call. We'll help you out. I'm going to turn it over to Miss Cathy Costello.
Thanks so much, Scott, and thank you all for joining us today. All I can say is this has been an interesting year. If you
understatement of the day.
I know. If you thought you understood what was going on, please come and tell us about it, because let me tell you, there's no good answer. So we are going to do two things in this program. We clearly are going to go through the regulatory changes that affect the hospitals this year and next, and we'll cover all that, all the details that you need. But honestly, I think we all need to back up several steps and see what is going on around the compliance issues that are being put out in the regulations, because so much of what is not in the regulations are going to affect what you do in the next year or so. Here are a few examples of things that literally, some of this is as recent as yesterday, but it's all stuff you need to know. And part of the problem this year, and this is really, honestly, all kidding aside, has been the biggest challenge about this year, is that there are so many federal regulatory agencies involved in what's going on in trying to create interoperability across the country, that they're stepping on each other's toes, and they can't get a single focus as far as how they're moving ahead. And you'll see that in the next few minutes, see what I'm talking about. But the end result is it's a hodgepodge, but they're all things that you need to be aware of. Some are going to be more pressing than others, but it is not a clear path from here until the end of the year. It is a clear path, regulatory speaking. I mean, you always know that what's in the regs you're going to have to abide by. But this is one of those years that I would say you're better off knowing what isn't in the regs, because it may affect everything else that you do. So the four main agencies that we end up following and that I think everybody is affected by is the Office of Civil Rights, which actually oversees HIPAA compliance, Office of National Coordinator, ONC, which oversees the technical and standards side of what we all do, CMS, which oversees the payment and policy matters for both the hospitals and physicians, and SAMHSA, which oversees the drug and alcohol programs. Unfortunately, this year, all of those come into play, but they don't come into play in any coordinated way. So I'm going to walk you through things that are happening with each one of those agencies outside the regulations that you need to be aware of, because some of them are very important for what you're doing. As those of you who know us know, we start at the beginning each time we do a presentation to say where we are from the regulation standpoint. And this is one of those years where nothing's come to completion. If you think it looked messy earlier in the year, it's even messier now, because right now in the area that we all work in, compliance around technical reporting for technical functionality and getting upgraded for that, and the corresponding compliance on interoperability and stuff, we have had 7 regulations dropped this year. And of the 7 regulations, TEFCA is technically not a regulation, but it is a proposal from ONC. And of those 7 main ones, we have exactly 1 has become finalized, and that is the hospital inpatient rule. So we have all kinds of loose ends that are running around out there that give us an indication of where the feds are heading with some of these interoperability initiatives, but they don't give us very many answers yet. So the areas where they have released information or regulations but have not finalized it are the standards, which are very important because it sets the upgraded standards for CCDs. It talks about interoperability and information blocking, which I think is one we were all waiting for more guidance on. You know, as Scott and I had said early this year, that one regulation was more medical legal than anything we've ever seen. I mean, it was just so jam-packed full of legal terminology and safe harbors and all this other stuff. But the bottom line for what we all do is it was setting a pathway. This is what I feel, if you were asking me what's the main focus of this year, it was setting the pathway for patient access to medical records. And you'll see why I'm saying that in just a minute. So that came in. The payer rule on interoperability, which again involved patient access, it was setting out a new proposal as to what was required by the payers to make records available to the patients. TEFCA is, as we said, it's not technically regulatory at this point. It is more a proposal to create the interoperability infrastructure for the country that would create a governing body and new approaches to contracting for interoperability. So those are all out there. The bottom 3 rules are the payment rules for hospital inpatient, outpatient, and physician fee schedule. Lots of new stuff there. We will go through a lot of that, especially if it pertains to you all in the hospital setting. If there's a physician proposal that affects you, we'll let you know about that. The last one to drop is one from SAMHSA, which came out just in the past week, and is an update to the Part 2 drug and alcohol data, which was actually no surprise that that came out, because CMS is putting out hundreds of millions of dollars around for drug treatment around the opiate crisis, literally hundreds of millions of dollars. Ohio has easily, I mean, just from ones that Scott and I know about, has $50 to $100 million coming in this year in dollars attached to creating new treatment programs and education and all the other stuff. So this is not a surprise, but we'll show you what's in that particular proposed reg. What we thought mistakenly, I don't know why, Scott and I, we never learn from one year to the next. We expect January 1st comes about, and after we've, you know, had our champagne and stuff, we get giddy and we think, oh gosh, CMS is going to have like this really clear plan as to what we're supposed to do this year. And then the regulations start coming out, and then we're like taking 10 steps backwards. Well, this year has been especially, you know, challenging, shall we say, to find the thread that's going on with everything this year. But we believed, as I'm sure any of you who are geeky enough to follow all the policy stuff that goes on at the federal level in the technology area, we thought the interoperability summit that was hosted it was like 3 weeks ago, that ONC and CMS put on, was going to have answers to some of these things that they had proposed earlier this year that had never been finalized. And we thought, oh, this is great. They're just waiting to use this as form, and then they're going to tell us what they're doing with information blocking. They're going to tell us who's going to run the national network. They're going to tell us how they're going to make records available for care coordination that may otherwise fall under Part 2. And let me tell you, none of those answers came during that summit. I think it was, from my perspective, it was one of the most challenging parts of this. Is that I think the meeting in no way lived up to the expectation.
Yeah, we have to quit applying logic to our thought. When we sit down and we start, we take a guess at what CMS is going to do in the calendar year. So.
Oh, absolutely. But it isn't that we aren't getting the answers. It just is not in any organized fashion. So the interesting thing is, I mean, just to kind of tell you how this has all come about, they did this 2-day interoperability summit, and the hour that the summit closed, SAMHSA released the new Part 2 interpretive regulations. And it's like, they couldn't have announced that at the interoperability summit. What's the deal here? They didn't get around to naming the RCE, which is the Recognized Coordinating Entity, which is the group that's going to oversee this interoperability network. They didn't get around to that either. That was not done until this past week. And the reality is that they could not move ahead in a coordinated fashion, but the information is leaking out. Let's see if we can put it together in some type of, I can't say it'll make sense, but at least you'll be aware of it. So first of all, let's start with this whole network that they're supposed to be creating at the national level, which is known fondly by everybody as TEFCA, which is both the proposal for the structure and the contracting terms that are supposed to be occurring as part of that. This is supposed to be a, quote, voluntary structure, but the reality is it is going to drive what we all do in the interoperability area. So pay attention to that over the next few months, because the group was named that is going to be leading that initiative, and they are the RCE, and that is the Sequoia project. If that name sounds familiar, it certainly should. We've had these people as part of our whole approach to national interoperability, really since, it's been 7 or 8 years since ONC got out of the business of running the HIEs themselves and defining what was going to happen and how it was going to be done technically and stuff. And that is, at that point, eHealth Exchange was created. So that was in 2012. It's really a run up to 2014 standards. eHealth Exchange kind of set the standards. If you remember, what was it called? The win something? InWin. Yeah, was the standards that, the structure we were working under. So that was eHealth Exchange getting on its feet as ONC handed off to them all the technical guidance. As they got more experienced in it, they now have moved on to care quality, which I know you all have heard about. Commonwealth and care quality are the 2 big initiatives at the national level to connect people through, depending on what the technology is, to allow documents to flow. The Sequoia project renamed itself, but that's who they are. They were eHealth Exchange and Care Quality, and they're now called the Sequoia project. And they actually are also the group that manages the DRSA. For those of you who follow contracting with federal government, that's the document that's used that everyone has to sign to exchange records with the federal government. We certainly have, and I think many of you have. And in case you're wondering, our coverage covers you as members in Ohio. The Sequoia project has now gotten a third spoke to what they do, and that is they have now been named the TEFCA RCE. And this literally just happened within the past few days. This is important for you to know because the two things that they are going to concentrate on to get this national network up and running is they are looking at the technical standards for interoperability between HIEs. Like you all operate right now under the technical standards that are put out by ONC for individual hospitals, individual physicians. Well, this would be like the broader scope, like how do we in Ohio exchange records with California or Florida or something like that. So they're going to be involved with getting everyone together and arriving at the mechanism that is going to work technically to allow that to happen. And probably just as important, or maybe even more important, they're looking at what legal agreements would need to be structured to allow those records to flow. And that is very challenging because every state has their own consent policies. And you have to be aware of that. And then you have to decide if people like you all who contract with us would need to make any changes in your contracting, or if we would need to make our contracts different to exchange with another state. That's all stuff that is, to all of us, is theoretical right now, but over the next couple of years will become more of a reality. Now, Sequoia got $900,000 to get this project up and going. So again, just watch for the information on that over the next few months, and you'll see that they're trying to fast track the development of this TEFCA national network. Okay, this next area, and I'm sorry we're jumping around, but that's the nature of dealing with 4 different agencies and what's going on. This one, as I said earlier, I think this is going to be your highest priority, honestly. When you get all your HIE functionality in place and stuff, you're going to have to turn your attention to patient access issues. And I think we started saying this like last year, the year before, that we could just, there was something about information that was flowing on TEFCA and in the regulations that pointed us to the idea that patient access was moving up the priority list for CMS. So I just want you to really pay attention to this because this is brand new information. It just came about this week. But there was the Office of Civil Rights, which, as we had mentioned earlier, is responsible for overseeing HIPAA compliance, released what I call a consent agreement or a settlement with a academic teaching center in Florida, in which the teaching center was fined $85,000 for not releasing information in a timely manner to the patient. They also had to sign a consent agreement or a settlement, which has some terms that I think we all need to be aware of, because what Scott and I have been saying with the whole API movement that is in the hospital regulation, in the physician regulation, this requirement to have the technical connections for phone apps, you get into this question about setting policies. So here is what I want you to walk away with. If you nothing else today, look at this, because I think this is the first step in a multi-pronged approach to patient access that's going to cover TEFCA, API, and information blocking about how patients should have access to the records. So in this case, as besides the penalty, the hospital had to agree. They were basically put on a compliance plan, corrective action plan for a year. And during that time, they are being required, this is the last bullet on this slide, and this is what you want to walk away with, it requires the hospital to develop access policies to medical records and distribute those policies to members of the workforce and to relevant business associates within 30 days. So this is what we have been saying all year. I know we sound like we're broken record on it, but telling people to make sure that they had a policy around patient access. With this introduction of the OCR, as I said, it's the very first time there's been a suit involving patients' right to access their own records in a timely manner. This is like the shot across the bow. Every hospital in the state should be working on a policy to explain how patients access their records, whether it's through the portal, whether it's through the new API app procedure, and they need to get this in writing and get it disseminated. If you need help, I know we've been working on just a draft copy, but it's just something that people need to spend more time on than if they do not have something in writing yet. Okay, as part of the API, because as we said, that as part of the API requirement is to have policy in place. But let's look at what's going on with API in all these regulations together. So the transfer through the portal is done with the CCD, which is a document, and the way that CMS wants us to be moving with this API is for discrete data transfer through phone apps. And we're not there technically. You all could tell us better than Scott and I can tell you that we're not there technically in getting these phone apps up and running smoothly and then having that data flow. But you need to be working on it because that is what's required in the regulations. The payers too were part of this access to patient records, and their regulation has not become finalized, but they were expected by 2020 to have all these different types of payers: Medicare Advantage, Medicaid, Medicaid managed care, qualified health plans. All were expected to make their data available to the patients through phone apps. And this is the type of data that they were expected to make available. So what you're seeing is not just claims data, but also clinical data. Don't ask me the overlap between what hospitals and physicians do to release information to the patient and what the payer is supposed to be doing. I'm just telling you that in these separate regs, it shows up where each group, hospitals, physicians, and payers, have to make whatever data they have available to the patient. The last thing that we're going to look at before we get into the actual regulations is the SAMHSA's proposed rule, which is the rule related to 42 CFR Part 2, release of data. And so this is specific to drug and alcohol programs. We looked at the regs. It was the shortest of all the regulations. It was less than 100 pages.
We had high hopes for this one too.
Yeah.
But it just didn't pan out really.
And just so that people recognize the difference as to what you're seeing in the SAMHSA regulation, SAMHSA does not have the authority to rescind the Part 2 standard for drug and alcohol records. That has to be done by Congress because it was originally passed by Congress. It is statutory language. And even though there has been a lot of discussion in the past year of dropping the Part 2 standard back down to a HIPAA standard so all the drug and alcohol information could flow in the same way that your other clinical data does, the reality is we aren't there yet. But what we have seen is that there are 2 proposals in Congress to change that standard. And in the meantime, SAMHSA put out this proposed regulation in which I would say that it's not new what they did, but clarifying the change in the regulations they made a year and a half ago. And it's important only in the sense from the technical viewpoint, since you all are looking at this technically, just pay attention to what they did here, because they kind of drew a very clear line on Part 2 data and primary care data. And they made clear that primary care providers have every right to put in their medical record, you know, if the patient's been treated for a drug condition, or, was released from the hospital, after an overdose or something, all that can go into the primary care record. And that can be moved around in the same way that your normal HIPAA data is. But what they're saying is that if you receive a actual record from a drug or alcohol treatment program, that you need to do one of two things. It needs to be kept segregated from the primary care record, so that if there's a query and your primary care record needs to be moved around, that it goes under separate consent policies. That's one way of handling it. The second way is to have a vendor who segregates or segments that underlying records, so the Part 2 is considered separate data within the record and doesn't move in the same way. The reality is most vendors are not able to parse the medical record to that degree. So from the technical standpoint, you should be creating a separate file for the Part 2 data that your organization might receive. And as I mentioned, they're very clear. They're very clear. That's one of the reasons they put this regulation out, is that the primary care practitioner has every right to put information in their record about the patient's treatment and stuff. What they cannot do is incorporate the whole medical record from the Part 2 program into their record and have it identified as coming from a drug treatment plan. But they can certainly query and get that information themselves. They can talk to the patient about it. They can do their normal documentation, but they just can't republish that information as drug and alcohol record unless they have the patient's specific consent. So watch that one. That is not a final rule. The comment period closes in October for that, but it is designed to clarify how primary care records and Part 2 records can be handled by one organization. Now, getting on to the rules, there's just a couple kind of cleanup things before we get to the technical areas of the rule that are in this case, the proposed outpatient rule. And for hospitals that charge facility fees for their physician office visits. So physician office billing is called E&M coding. I think most of you are aware of that. And a lot of hospitals have gone to billing facility fees for their own physician practices when there's a physician visit. The year before last, actually last year, starting this year, there was language in the regulations to roll this back so the hospitals could not bill additionally for facility fees for their physician-owned practice office billings. And so this year there was a 30% decrease in reimbursement in this area. There is supposed to be another 30% decrease beginning in 2020, which would mean that by the end of, or in 2020, that hospitals would be paid only 40% of what they had been getting for the physician office visits. There is a group, as you know, CMS has a lot of physician advisory groups, and there is one specifically for the hospital outpatient rule, and that advisory group has advised CMS to freeze that cutback until the impact of that could be better studied, because there is a adverse effect, especially for groups like freestanding cancer facilities were really getting hit by this. And there actually had been a lawsuit brought by the American Hospital Association about this cutback that has not been decided yet, but that is something that is in the outpatient rule. The second thing in the outpatient rule is the Hospital Association also brought suit around 340B drugs, which are those that are used to subsidize drugs for low-income patients. And there was, again, CMS was doing a major cutback on what they were going to pay for these drugs. And the American Hospital Association led about 40 hospitals in challenging this cutback. And at this point in time, the AHA has won the first round in this cutback. And CMS says they're going to appeal, but if they are not successful, they are going to have to reimburse all the hospitals for the money that they had taken away last year and the year before for the 340B acquired drugs. So what is being raised in this rule is the recognition that they are going to have to reimburse it if they do not win the appeal, and asking the hospitals how they could go about doing that so it could be in a budget neutral manner. So again, that's something that technically is going to be going on outside the rules, but just be aware of it. If you are a hospital that has relied on those CMS subsidies to pay for the drugs, you want to be paying attention to how that is going to be resolved between the courts and CMS. Okay, one last thing before we get in the technical side of the rule. These are the financial guidelines for the hospitals for this year. This is a final adjustment of the market basket adjustment that the hospitals get. So that's your standard annual increase in payment from CMS was settled on to be 2.6%, which is a little bit lower than what's in the proposed rule, but this is final. So 2.6% is the market basket adjustment for all the PPS hospitals for 2019-2020. The other things that CMS looks at every year in their reimbursement to the hospitals is value-based purchasing program, which is your bonus program for whatever you earn for your quality, cost, performance, and patient satisfaction. And CMS can move the weighting around for the 4 categories that they draw data from and create towards the hospital reimbursement. They have standard how they're weighting these categories. So each category, your mortality, your patient satisfaction, your quality, safety measures, and your cost are all 25% of your value-based purchasing figure. So that's been standard now for the past 2 or 3 years, where it's been 25% for each one of those. Be aware that there is a proposal floating around to change the value-based purchasing program. It was not adopted this year, but it will probably come back again in 2020 as a new incentive program for the hospitals. The cost factor for the hospitals continues to be based upon your episodes of care performance, and it's the Medicare, excuse me, Part A and Part B costs for 3 days prior and 30 days after a qualifying inpatient stay. Excuse me, sorry, give me just one sec. The programs that go in financially for the hospitals, as we said, are value-based purchasing. That is a budget neutral program, so it can go up and down depending on how much money is available for distribution. Promoting interoperability is a flat 2.25% penalty for the hospitals should you not report your promoting interoperability. So make sure if you're having problems, if you're moving to a new system, if you had some type of functionality issues, that if for some reason you cannot attest, that you are looking for the hardship exemption, because you don't want to be left with a 2.25% penalty for a year. Hospital acquired conditions is like a bright line. Either you are above the benchmarks nationally or you're below it. And if you're below the benchmarks, then you are getting a 1% penalty for all your Medicare fees that or Medicare payments that they make to you. The readmission reduction program is a sliding scale up to 3%. And again, that's structured the same way it has been for the past few years. And the dates that they covered are listed in the right-hand column. For those of you who are hospital people, you need to keep an eye on your physician reimbursement only because of the attestation requirements have gone up and the penalties. So in 2019, if your physicians do not report and are required to, because they might be exempt, but you need to find that out. And if they are not exempt and do not report, there's a 7% penalty, and next year it'll be a 9% penalty. This is a new area. It is in the physician rule, but I pointed out because there is a technical component to it that you need to be aware of. So as we were talking about, the reimbursement for physician office visits is changing. This is a high priority for CMS on the physician side, is to change the way that physicians bill and get paid. And for those of you who do not have to deal with billing and coding and revenue cycle issues, the documentation for that has been what they call medical decision making, where they document in the record why it took, why it should be a level 5, why it's a complex patient. Or you can look back on old CPT code books put out 20 years ago. And what CMS is proposing for this, starting in 2021, that actually there would be a third way adopted for documentation of payment for complexity. And this would be based upon time. So time would be the criterion. CMS put in these charts about, if you're 15 minutes or you're 30 minutes or you're 45, this would determine how much you could get paid and whether it's considered a complex patient. The reason I'm bringing this up to you is you need sometime in the next year, as your revenue cycle people look at this, to talk to them about your EHR and how it documents time for these visits. Because that will be, my guess is that even though you will continue to have different ways that you can provide documentation to CMS and to the payers for what your physicians do, the reality is I think more and more people will go with time because it'll be shorter, easier to determine, but you will have to see how that is documented within the EHR system. The last thing on the hospital side, before we get to the specific rule requirements, is hospital star rating. And those new documents for what's on Hospital Compare were published in July. It was July or the beginning of August. We saw, beginning of August, we had the newest round. So if you haven't looked at your hospital recently, you may want to go in, because that publicly reports your readmission rates, your hospital-acquired conditions, your patient satisfaction, all that stuff gets publicly reported. And then you will supposed to get a star rating, 1 to 5 stars, that kind of gives patients an opportunity to compare you to your compatriots in the field and see what they think. The reality is there's been problems with the hospital star rating, and the reason was that the CMS was not applying the comparison correctly between hospitals. And so for this coming year, at least right now, CMS has, although they've published the data, that's the underlying data for the scoring, they are not putting new star rating scores out for the hospitals.
And they've actually pulled together a technical experts panel, and they're looking at how they can rework everything, how they can rework the formulas, specifically the comparison to ensure that it is truly a like organization.
Right,
so
right.
We're hoping here in a few months to see some more information on that.
So again, a lot of changes on this, and the one thing to point out as far as you're talking about underlying changes, another thing to keep in mind is the HCAP surveys are being reassessed right now, and they're probably going to be reworked. There's been quite a bit about that. They have panels and committees looking at that. And one of the things they're talking about doing is making the HCAPs online so the patients can respond online. But they also are going to be doing some changes to the measures. So again, if you're involved at all in doing patient satisfaction surveys, make sure that you keep watching for that, because we expect to see it within the next, I'd say, 4 or 5 months, what changes they might do in that area. Okay, so now I'm going to turn over to Scott to start on the technology issues, because there have been some changes between the proposed and the final for the hospital and physician side. And we just want you to be aware of what you need to be doing between now and the end of the year.
You know, the one thing we are really, really happy to see, not just the one thing, but one of many things we were happy to see get finalized, is the alignment of promoting interoperability across programs. So what I mean by that is the MIPS and the hospital programs now are once again reporting on the same set of measures for promoting interoperability. So what we saw in the final rule is that the electronic prescribing of controlled substances will be optional in 2020, required in 2021. It's also optional in 2019 as well. The ORS integration for the query, or what they call the PDMP query, here in Ohio we call it ORS. The web-based query will be allowed in 2019. They really didn't say in 2020 though. You know, CMS is trying to push along the vendors. If I'm a betting man, we're probably going to see that extended into 2020. We just don't know yet. The opioid treatment agreement, CMS they did recognize they put the cart way out in front of the horse. There's not one technology vendor that can support it the way CMS was hoping for this to go through. So it's going to remain in the program in 2019, but in 2020 goes away completely, not even a bonus in future years. Also, the HIE measure, the new measure where you have to receive or find information and then reconcile that information, can be excluded in 2019 if you're having vendor issues. It's just going to be a checkbox during the attestation process. If you do take that exclusion, we recommend that you have supporting documentation to show why you selected that exclusion. But then those 20 points will go to the HIE send, or the old HIE measure, making that worth 40 points. The API, we really thought this was going to be optional or they were going to give some bonus, but nope, CMS remained silent in the final rule, meaning we revert to what was proposed originally.
Well, which final last
year, yeah, I guess, final last year. So then that will become a base requirement in 2019. So this is what our measures now look like. You can see we've got a total of 105 available points. ERX, with or without EPCS is worth 10. That PDMP bonus, that 5 points, is only available if you report ERX with the controlled substances included and have at least one provider perform an EPCS. For your HIE measure, you can see it's split 2020 across the send and the receive and reconcile.
Yeah, and the only difference between this and 2019 is under the e-prescribing in 2020, the whole opiate treatment agreement goes away. So if you're wondering what's going on in 2019, it looks just like this, only there's no opiate treatment agreement option.
Right. And then your patient portal, of course, that does include the use of an API, all included in the same numerator denominator, worth up to 40 points. And your public health reporting, any two get you 10 points. And we've looked at this a lot because we do have some organizations that have one, well, not on the hospital side, everybody's immunization and syndromic at a minimum. Some folks doing ELR, but you can technically exclude one, choose one, still get the 10 points if you need to do so.
This is just a reminder that when you're doing query and retrieve as part of that HIE measure, to recognize that if you're using our community health record, you can access Department of Defense and VA records straight out of the community health record. So if you have a patient you need that information from, it's easily available. If you need help locating it, let us know and we'll have someone come out and visit. Okay, this is our apps thing, going back to our long discussion at the beginning. But just to, if you're constructing a policy around this, you know, make sure that you're covering patient identity verification, what security that you would be looking at. Do you have a committee or something internally that decides which apps you're going to accept from the security side? And then talk about a policy that explains how you give access to your patients for their information.
You know, from our discussions with our clients, what we're seeing is there are really right now very few apps that have been developed. You know, there's some web-based apps folks are looking at. Some of the EHR vendors developed a representation of the portal that uses the API functionality. However, we do believe that over coming years, the use of the API is going to explode. And when that happens, and there are many, many vendors, it's going to be even more important to truly vet these apps, because, you know, some of these apps are going to be written in a dimly lit basement, and who knows how well they'll protect things.
And just so you're aware of it, the thing that we've seen as these proposed regs have come out, the last one being the physician reg, they've gone from, at the beginning of the year, talking about possibly doing app registration through ONC, so that you'd have information on it, to, in the physician fee schedule reg, they're now talking about app certification. So we'll have to see how that develops, but just be aware that the CMS is responding to hospitals and physician concerns around security of their EHR systems. Here's the timeline as we saw in the last round of proposed regs, that we're still required to have the technical interface in 2019 with one case being tested. We don't know if that's going to change as the regs become final later this year. 2020, the payers were supposed to be getting their apps in play for the patients, and 2021, 2022, if they in fact go with some type of registration, that would be when that would be required for the phone app people.
So now we're going to switch over and talk about appropriate use criteria. First thing, appropriate use criteria is not part of promoting interoperability. It is a technical requirement that lives outside of the promoting interoperability, or on the physician side outside of the MIPS program. Now, what AUC, or appropriate use criteria, is it was developed by CMS. The idea came from CMS as a way to ensure that physicians were selecting a study that was supported by information in the EHR, clinical information, and really truly as a way to control cost. If a standard film would work instead of an MRI, let's not order the MRI. So what this does is, when you select a high dollar diagnostic study, it collects information out of the EHR and compares that, or runs that through a clinical decision support mechanism. At the end, whether it is appropriate or not, the provider or whoever is entering this order will get a display showing if that order was deemed appropriate, why it was, and if it was deemed as not appropriate, then what were the factors that led to that decision. This appropriate use criteria, gosh, it was first talked about back, I want to say, in the 2016 regs. Yeah, and you know, it's kind of where they built the base, and then each year in the hospital outpatient rule and the physician PPS rule, they would add a little bit more to the program. CMS did kick the program back. They just kept delaying it as long as they could by regulation. They could not extend the program any further than 2020. But what they did is kind of a little workaround, is they made 2020 a testing year, meaning that no claims would be denied if it were missing some of the G codes and some of the information on the claim form. And then we're going to go into full program implementation in 2021, when you could be denied payment. Now, there are certain areas where you must perform the AUC, and other areas where it's an optional, but your required areas are in your physician offices, your outpatient departments, in the ED if it's a non-emergent patient, and ambulatory surgical centers and diagnostic testing facilities. You do not need to use AUC in the inpatient setting, in the ED if it's an emergent patient, or if you're ordering this study to determine if the patient is non-emergent or emergent, then that is an excluded area as well. And then if you're having some issues getting the AUC working, then you can do a hardship there as well. The priority areas are those high dollar studies, those high dollar diagnostic studies, CTs, MRIs, just the big dollar things that get ordered on a daily basis. Now, CMS did finally realize that running through the support mechanism, the clinical decision support mechanism, can be timely because there may be a couple pop-ups. So what they have allowed for is much like back in the days when we were monitoring CPOE, it does not necessarily need to be the physician who is entering the order. It can be any staff member who has the training and experience to respond appropriately to the pop-ups, and if an order is deemed not appropriate, to communicate that information back to the physician so a change can potentially be made to the order. So again, it can be any member of the care team with appropriate, if you follow the same standard as CPOE back in the day, you're going to be just fine on this one. There are quite a few CPT or HCPCS numbers where the appropriate use criteria must be ran, and these are all the numbers here. We've got 2 pages of them, so a lot of studies have to have the appropriate use criteria ran. Now, we've been saying for a while with appropriate use criteria, there's information that needs to follow the claim form. Well, the first one that must follow the claim form is a HCPCS modifier on the same line as the CPT code for the diagnostic study. And this HCPCS modifier will show whether or not the AUC had been ran, if it was appropriate or not appropriate. The most common HCPCS modifier you're going to see is that very last one on this page, QQ. The other ones will be, necessary for, if the AUC came back and was not appropriate, or if you are a hospital, you are the, performing the study, you may not get the AUC information. There's a HCPCS modifier for that as well. And by including that, you guys will get paid for the technical and the reading component by ensuring that the HCPCS modifier is there. There's also some G codes that have to appear on a blank line, and really all this G code is it identifies the clinical decision support mechanism used by the AUC. For example, NDSC G1004, this one's used by Meditech, and we found to be the most common AUC.
Yeah, and that should all drop automatically onto it. You shouldn't have to code your system for this.
Yeah, and that's the expectation of CMS. Everything should flow through your system. That's not to say that day one that you might have to do some manual work as your EHR developer gets this AUC more tightly integrated with your EHR. We've heard that some vendors charge 10 grand, some vendors charge 70 grand for AUC. We've also heard that there are some free options out there, though the free options are web-based and they require you to key in or copy paste some information from your EHR. So now we're going to flip over real quick. We're going to talk a little bit about quality reporting. The measures you see here on your screen, these are your 2020 ECQMs on the hospital side. You must report 4 ECQMs for 1 quarter. This is a requirement of promoting interoperability. Right now we are still in a benchmarking year. If you think back, we did at one point have 16 measures. We're down to this 9 measures. Then these are your hospital outpatient.
Yeah, there's only been one change.
Yeah.
In 2019, It's the same on both the hospital, outpatient and inpatient. It's 2020 that you start seeing the changes.
Right.
But they're very, very slight. We're going to show you 2021 where there's actually more changes.
Yeah, so in 2021 for your hospital ECQMs, we have one big change here, and it's highlighted in red. There's a new quality or ECQM 3316E, safe use of opioids, concurrent prescribing. Starting in 2021, this must be one of the 4 ECQMs that you report. Every hospital in the country is going to report this quality measure, and then you can just pick 3 out of the remaining list of ECQMs. Now, I'm going to go ahead and just jump right over to the kind of the spec for this measure. But what the safe use of opioids looks at is at the time of discharge, it will look at your discharge meds, home meds, and active meds. And this is discharge from an inpatient setting, ED, or observation stays. When it looks at those meds, if it determines that there are 2 opioids or an opioid and a benzo active on home discharge or active meds, the patient will then be placed in the numerator for this measure. This is a reverse measure, so we want to keep patients out of the numerator. So 2 opioids or an opioid and a benzo puts the patient in the numerator. Now also, we're right now for readmissions, you are judged on NQS 1879, which is the hospital-wide readmissions. CMS is proposing a new hybrid measure, which is NQF 2879. What this measure does is it combines a subset of clinical information with the claims information they've already been collecting. This is something CMS has done for the last couple of years. They've been collecting 2 quarters worth of data from hospitals that volunteered to participate. Starting in 2021, July 1st, they're going to open up a new voluntary period. This period will have 4 quarters of data, followed by another voluntary period in 2022. Then magically in 2023 becomes a required measure. 4 quarters of information must be submitted. And again, CMS is going to combine this with your claims data, the clinical data with your claims data. On this screen, you see the subset of clinical data that will be submitted in the QRDA file that will then be melded with the claims data. It is the first occurrence of every one of these data points that will be included in the QRDA.
Right. So the last thing we want to point out, and before we open to questions, is more and more, practically every system in the state is involved with the Ohio Medicaid CPC program. It's a primary care program to manage, coordinate care for your Medicaid population. And the reason we're bringing this up is for the technical issue. Right here, there's a new part of the program called CPC for Kids, but at the bottom are the new requirements for the overall CPC program. And please note that you are going to have to demonstrate coordination on behavioral health issues for all your patients. And so you are going to have, one of the things you're going to have to do is make sure that your primary care and ED are using screening tools and to coordinate care with the community, that they are looking at whether it's the SBIRT, the ACEs, whether they're developing information on social determinants. But from a technical viewpoint, please review with your clinical people what is being done to screen for behavioral health issues. The second thing is you have to demonstrate that you have a referral pattern in place for these behavioral health patients when they're positively assessed as having a problem. So that's things that I think you would want to be aware of. And the very last thing, as far as a quality metric that you're going to want to know for both the hospital and physician, is you may have heard that there was some pulling back on the question of tobacco use, tobacco cessation as a measure. And the only reason that that's getting pulled back at all is because they're trying to figure out how to include vaping as part of that metric. So you want to be looking at how to capture information on patient vaping, which, given the information that's come out this week, is clearly something that you're going to want to be documenting within your record. So with that, we have finished walking you through the various requirements for the hospital reporting this year. So let's see if we have any questions.
All right, let's see. All right, to be counted as, let me make this a little bigger here so I can see it better. Give me a second, I apologize. I closed the window. All right, here we go, questions. To be counted as the receive, I'm assuming for the HIE receive and reconcile, does this need to be a patient that is new to our organization, or can it be for a patient that has been seen previously? And the answer is yes on both. This measure is really differs from other measures we've seen in the past. The way it works is a patient will be in the denominator for this measure if you receive a CCDA via direct, or if you query an HIE and find information on the patient. That puts them in the denominator. To put them in the numerator for the measure, you have to reconcile the problems, allergies, and meds. And that reconciliation process is written a little different in every EHR, but they get in the denominator by either receiving or finding a CCDA, and the numerator by doing the reconciliation. That can be a brand new patient to your practice. It could be a long-term patient, really not specified in the rule. That's the only question. That's hard to believe, Cathy. So, we want to thank everybody for taking the time to join us today for the webinar. We do have another webinar next week. It's going to be on the 17th at noon. It's going to cover the physician PPS proposed rule, the changes that they're proposing to both MIPS, and outside the MIPS, we've included a few little billing changes and a few other regulations. But if you've not registered for that, please do so. If you need the registration information, shoot Cathy or me an email, and we'll send you the information on that webinar. This webinar has been recorded, will be posted to YouTube, and all attendees will receive a copy of the slides.
Thanks again, everyone. Have a great day. Talk to you soon.